The cervix can tear spontaneously or after precipitous delivery, cesarean delivery, or labor with a cerclage in place. Always inspect the birth canal after vaginal delivery. If vaginal bleeding is brisk or excessive, suspect a cervical laceration. Have an assistant hold retractors if necessary. If a cervical laceration cannot be ruled out, examine the canal in an operating room or another place with proper viewing conditions, such as with optimal lighting and in a high lithotomy position. If necessary, use anesthesia or analgesia. Use sterile gloves and generally a mask. Useful equipment includes 2 ringed forceps and retractors, as well as suture materials. Place 1 ringed forceps at the 12 o'clock position. Then place another at the 2 or 3 o'clock position and closely inspect the area between them, which should now be less obscured by bleeding. Then remove the forceps from the 12 o'clock position and place it at 5 or 6 o'clock. Continue this process until the entire diameter of the cervix has been examined. If a laceration is found, place ringed forceps on both sides of it. Then place a suture at the apex of the laceration. Sizes 0 to 2O polygalactin or Vicryl are best. Continue the suture in a running locked fashion. If the apex cannot be clearly seen, place a suture closer to the distal end of the cervix than the apex. Then pull that suture towards you so that you can better see the apex and direct the repair toward the apex. Close all running sutures, whether at the apex or base of the suture, with surgical knots. If bleeding persists even after suturing the laceration, pack the vagina to help with hemostasis. This shows packing being inserted in a woman who has a catheter.